First of all, if you are a woman who has never heard of prolapse, please do not go and Google vaginal prolapse, like any sort of prolapse, because you're going to be horrified with what you see on Google. So it's really the first things that pop up on Google are always the worst, right? The jaw has a huge connection to the pelvic floor. So I'm looking at that. I'm looking at your breathing. I'm looking at your core contraction, your muscle strength in your legs, your foot posture, all of those things first before we dive into any sort of internal work.
Welcome to the show, everybody. I am in here today with Casey Mosos. Welcome, Casey. I'm so happy to introduce you to our listeners today.
Thank you so much. I'm so happy to be here.
Yeah. Well, you and I live locally here in St. Augustine, Florida, and I've had a chance to meet you in person and spend some time with you. And you and I spent quite a bit of time. We met for coffee maybe 2 months ago, and it was just constant conversation. It was because we share so much. So I was excited to bring you in. So what are you hoping that they walk away with today?
I really hope that any woman or man listening to this episode can really gather how important it is to take care of your body, your pelvic floor, your bladder health, if you've been dealing with something for years, how important it is to seek specialty help and actually take care of it for once and for all. And that the things that you struggle with on the daily that maybe sometimes feel intimate or sensitive and you don't really want to talk to anybody about them, they're most often not normal. They might be common, but they're not normal. So what I would love to do is normalize those things that are not so normal and encourage women and men to take care of their bodies and go seek help.
Yeah, I love that. And that is my philosophy as well, is to educate and to inform, because the better we understand our body and what it should be doing, or when it's not doing what it could and should be, and those symptoms that kind of tie into it, it's real important. So what got you down this road?
Yeah. So I chose to go into physical therapy. My grandmother had actually just broken a hip and had the hip replaced. And I went through the rehab process with her, and I saw how powerful it was. And I also saw how important it was for her to move her body and exercise, getting her to where she needed to be with so much success and no medicine. It was all hands-on. It was exercise. And I was like, wow, I really love this. Because I was always drawn to health sciences and medicine, but I just didn't know, did I want to go down the MD route and be very, westernized in medicine? And then I found PT and I was like, wow, you could do all of this with your hands and with exercise. So I loved that. And that's kind of what led me to physical therapy. And then, that kind of grew from there. My knowledge on the human body grew, and then my interest in pelvic health grew from there.
What exactly is the pelvic floor?
Yeah, so the pelvic floor is super important, and it's actually, I describe it as being a little bit more than just the muscles in the pelvic floor. So typically when I have a patient come into me for the first time, I'm describing to them that the pelvic floor starts at your diaphragm, which sits underneath your rib cage, and then extends even beyond the pelvic floor. I typically include the adductor inner thigh muscles in that puzzle, and then also the foot mechanics. That also plays into what the pelvic floor does. So, the pelvic floor itself, they're muscles that support your pelvic organs, and they're really important for, sexual health, things like that. But it extends beyond that. Our body works a lot in harmony with the pelvic floor. So a lot of times when people are having issues with the pelvic floor, it could be from their breathing mechanics or their foot mechanics or hip mechanics. So it's a lot more than what people think.
Yeah, I love that. So what are some signs that our pelvic floor isn't functioning well?
Yeah, there's a lot of really common ones. A lot of signs, yeah. But then there are some that people don't really think of very often. So, of course, the obvious ones like leakage, whether that's your urine or bowels that you're having dysfunction with, pain during intercourse, or feelings of heaviness in the vagina or the perineal area when you're doing core exercises, doming of the core, not feeling like you're connected to your core. Those are all kind of really outward obvious signs that there's some pelvic floor dysfunction. But sometimes people also present with low back pain or SI joint pain,
Hmm.
or when they're lifting, they don't have a good stable base at their feet and their toes are doing all sorts of wiggly things trying to
Hmm.
stabilize their body. Those can all be outward signs of pelvic floor dysfunction too.
So
Yeah.
what are some symptoms? I'm as you're talking about what it means when it's functioning well or not well.
Mhm.
So what are some common symptoms? And you can use examples maybe of women that you've helped or men
Mhm.
even. We don't want to leave men out of the conversation here.
Mhm.
I think we do think of pelvic floor as strictly the man's or the woman's anatomy, but obviously a man has the pelvic floor as well. But what are some
Right.
symptoms that they're coming in and maybe they don't realize it's pelvic floor related, but it does go back to, just that anatomy?
Yeah. So a lot of times I have women come in with kind of like I mentioned, a low
Yeah.
back or SI joint dysfunction. They've been to tons of chiropractors and physios in the past. They've done the steroid injections. They've done all of the
Mm-hmm.
things and it's not resolving. So
Yeah.
I see that a lot of times because, our spine connects with the pelvis. And, a lot of the times either it's a referral pattern of pain or it's actually just the mechanics of the body that are not functioning well anymore because of the dysfunction in the pelvic floor. So I do see a
Mm-hmm.
lot of women who present with your typical chronic low back pain or SI joint pain, things like that. And
Okay.
then we assess the pelvic floor and there's a ton of dysfunction in the pelvic floor. And that could be
Okay.
tightness, weakness, a little bit of both sometimes. And once we
Mm-hmm.
address that, the body works so much better and more optimally. And once you get the pelvis kind of working optimally, then the low back can respond better, the core can work better, and it
Mm.
all functions better as a team.
Okay. Yeah.
Yeah.
It's definitely a whole body approach. Definitely. It sounds
Yeah,
like, yeah. So what
absolutely.
happens? Let's start with childbirth because this is something that I've kind of dug into my own area of health with pelvic floor using vaginal estrogen, and we'll talk more about that and the benefits of it. I really want to definitely hone in and emphasize that today.
Mhm.
But let's start with a woman in childbirth years. And
Mhm.
I do know, and there's a statistic, or maybe it's not even a statistic. It's just, it is or it isn't. But in Europe, other countries, following delivery of a baby, pelvic floor PT, physical therapy, is part of the postpartum treatment.
Mhm.
Not so here in the United States, right?
Yeah, yeah.
Yeah.
And you're gonna have to kick me off my soapbox at some point because this is one I can stay on for a
Mm-hmm.
long time. But
Mm-hmm.
yeah, it's incredibly frustrating in our healthcare system. Women who have just had a baby are typically told either they're told nothing about their pelvic floor or
Mm-hmm.
they're told, wait 6 weeks and then you can get back to what you were doing previously. That is
Mm-hmm.
so broad and so confusing, especially to somebody
Yeah.
who's not very connected with their body. What if I was running 10 miles a day before my baby? I can just 6 weeks after I deliver my baby, I can just start doing that again. That doesn't feel
Mhm.
right.
Mhm. Mhm.
So yeah, it should be a part of postpartum care and it should be encouraged by most doctors, hopefully all doctors eventually,
Mhm.
to either refer their clients to physical therapists or have physical therapists that they work with because it's so important to have foundation for what you know about your pelvic floor. And then when you get into exercise and daily life again,
Yeah.
it's going to be an entirely new routine when you have a baby, right?
Mhm.
So
Mhm.
working with your baby and their schedule and then also trying to reintegrate a schedule for yourself to take care of your body is an entirely new process to most people and most first-time moms, right?
Yeah.
So I think the struggle is that it's been for so long, the standard is just wait 6 weeks, you'll have your 6-week
Okay.
follow-up, and then you're most likely cleared for everything. You're cleared for intercourse, you're cleared for exercise, as long as everything looks good. And the problem with that is that the pelvic floor muscles are typically not being assessed for their strength, their integrity, any other symptoms that the mom might be having but didn't discuss with their doctor, right? They just think is
Mhm.
normal because I just had a baby. right?
Right, right.
If I'm having heaviness in my pelvic floor and I have no idea what that means, that maybe it's just a symptom of, how I'm supposed to be feeling after I had a baby. But what if
Hmm.
that's the beginning of pelvic organ prolapse and we have either a uterine prolapse, bladder, rectal prolapse occurring and it's in its beginning stages and it's just
Yeah.
starting to feel heavy and compromising the pelvic floor a little bit. And then we just get back into our normal activity like nothing ever
Yeah.
happened. That
Hmm.
prolapse is most likely going to worsen. And
Hmm.
the mom had no idea what they were supposed to be doing to make that
Yeah.
better.
Right.
So it should be the standard of care that moms can have pelvic floor physical therapy right away after. I mean, if they were assessed,
Hmm.
very soon after delivery, whether that's vaginal or cesarean, I believe they'd have so many better outcomes and they'd feel
Sure.
so much better and more confident in their body after giving
Hmm.
birth.
Again, preventive care, right? Let's take a
Yes.
look, let's assess so that mom doesn't have to keep making excuses or accepting about how her body has now changed post birth. But again,
Exactly.
I think years later, because this is becoming a topic now that I'm in my late 50s, again, this was not happening when I was childbirth years. So I had my daughter a little over 30 years ago.
Mhm.
This was not even a topic. I didn't even know much about physical therapy back in those days, or just all of the advantages of this, like you say, the manual therapy to help the body move better and function
Mhm.
better. But I think of, and again, we're going to talk about the vaginal health here in just a minute and how
Mhm.
important estrogen is. So what happens when estrogen, and let's just jump into that. And this happens after childbirth as well. So these
Mhm.
hormones are always fluctuating. That's just how dynamic us women are, especially during our reproductive years. And it gets even worse as perimenopause comes up. But I think that's when some of these symptoms that you're talking about, and hopefully you're treating these women sooner than later, and they're coming to you sooner than later,
Mhm.
in order to identify it so it doesn't worsen. So we're not chasing the pain and the symptoms and those, that dysfunction. I think of the leaking. I
Mhm.
think of the prolapse. A prolapse is just a term maybe we're not used to hearing. Can you explain what prolapse is? I'm hoping, and maybe I'm hoping women do or don't recognize this when they hear the definition, because I don't want anybody to be experiencing this, but it sure is nice if you understand what may be happening. So what
Yeah.
exactly is prolapse?
Yeah, absolutely. First of all, if you are a woman who has never heard of prolapse, please do not go and Google vaginal
Yeah.
prolapse, like any sort of prolapse, because you're going to be horrified with what you see on Google. So it's really the first things that pop up on Google are always the worst, right? And
Yeah,
so that's
right.
what happens a lot of the times when women Google things and their doctors aren't telling them what this could be, then they see the worst case scenario pop up on Google. And they're thinking either one, I'm terrified that that's going to happen to me, or two, that doesn't look like me. That isn't exactly it. So mine must not be prolapse, right?
Okay.
So a prolapse can be a couple different things. So it can be a uterine prolapse where your uterus is actually descending into the vaginal canal. And
Okay.
there are different grades of prolapse. So that's something you can talk to your OBGYN about during an exam. If you do feel as though you may have a prolapse, they're able to tell you a little bit more about the grading of that. And we can tell you a little bit more about it, but we're not supposed to be the one as physical therapists to actually grade the prolapse.
Okay.
But there are grades. So basically, how far the uterus is descending into the vaginal canal.
Okay.
And so, grade 1 prolapse is not very far into the vaginal canal. So it's not something that you could see or feel outside of the vaginal canal. So, but that grade 1 prolapse can still cause a ton of symptoms, heaviness in the vagina, irritation, feeling like you need support down there, right? It
Okay.
feels like maybe when you go to the bathroom to have a bowel movement, you might have to splint or hold your perineal area to feel like you can actually push your bowel movement out safely.
Interesting.
And then, so that's the uterine prolapse. And then there's a bladder and rectal prolapse as well. So from the front side or anterior side of the vagina and the back side or posterior side. And those two structures are not actually descending into the vaginal canal because of the vaginal walls that are on either side. But basically, those walls are kind of, pushing in slightly and causing pressure into the vaginal canal. And you can see that bulging on the front side or the back side with an exam that we do. So,
Okay.
and that really depends on the integrity of the bladder, the uterus, and the rectum and the structures that hold them in place, how far they are descending or how far they are kind of, moving towards a more downward position, putting pressure into or around the vagina.
Okay. Okay. Now, this could be, and I'll say aggravated, or this could be initiated obviously by childbirth.
Mhm.
But what if a woman has not gone through or experienced childbirth? I mean, I'm assuming age, time, gravity,
Mhm.
right? Did those
Absolutely.
factors play in? Mm-hmm.
They do. And I actually have a lot of young patients who have not had children yet. And they're thinking, there's no way that I have a prolapse
Mm,
because I have not had a child. I'm young, I'm active.
yeah.
But prolapse can be caused by other things like poor pressure management, right? So if you're, let's just say for an example, 20-year-old who's a CrossFit athlete and
Mm,
is not managing pressure well while lifting very heavy loads, all
interesting.
of that heavy load over time with poor pressure management can bear down on the pelvic floor and all of the organs that the pelvic floor supports and can cause prolapse or prolapse symptoms.
Okay. And this is a topic, if these things are coming up, again, we're talking childbirth or symptoms. So a OBGYN can assess this. Would this be the first step for a woman to visit a visit with their OBGYN?
Yeah, I would say, either a pelvic floor physio or an OBGYN. So again,
Okay.
if you come to me and you haven't been confirmed to have a prolapse, I'm able to see what's going on in the pelvic floor. And what we do as physical therapists is we do an internal assessment. Typically, it doesn't have to be done, but most often it's done on the first time or the second
Okay.
time visit. And so we're able to see and feel what's happening in the pelvic floor. And we use one finger for that examination. When you go into OBGYN's office, sometimes they will do a digital insertion with their finger,
Okay.
but other times it's a speculum exam. Either
Okay.
way, you can see the tissue integrity and if there
Okay.
is anything descending towards the vaginal canal.
Okay. Okay. Yeah, that's real important to know because, we get that question a lot. It's like, okay, but, what doctor do I go to? Because
Yeah.
we want to be able to get, personally, I think just going to a pelvic PT might be your first step.
Yeah.
I think it
Yeah.
sounds like, again, because it's an area of specialty. So I don't know how much training, a medical doctor that's trained in obstetrics and gynecology
Mhm.
and maybe they can diagnose it, but it doesn't sound like they're trained to treat it and to do the manual therapy. So you might as well just skip over to the physical therapist. Okay. Yeah.
Exactly. And it
Yeah.
depends. I always say that, with a grain of salt, if you go into your OBGYN and you're really interested in how severe your prolapse is, what I'll say is prolapse can be resolved with physical therapy and it depends on your body. Every person is different
Mm,
and it depends on how severe the prolapse is. If your prolapse is quite severe, there are also other things that you can try to help with the symptoms, such as a pessary, which is something that you insert
okay.
into the vagina to actually help to hold the
Mm-hmm.
structures up and to give a little bit more support internally.
Mm,
And that's something too that your OBGYN can help you with and help you get fitted for most of the time if they are one of those providers who can do that for you. So
yeah.
there
Yeah.
there are some things that you definitely, I'm going to say you should probably see your OBGYN and just see
Start there.
what their
Okay.
perspective is. But, if it's something that you've been dealing with for years, or even if you're just curious, is this what's going on? A pelvic
Hmm.
physio can definitely help you with that too.
Awesome.
Hmm.
Thanks for clearing that up. Yes.
Yeah.
I'm always thinking these things. So let's talk about estrogen, that magic hormone that
Yes.
I personally love. It has so many benefits in the body. So what happens to the pelvic floor as our estrogen is starting to do a decline?
Yeah. So as estrogen decreases in the body, we see a lot of changes, and a lot of women. I'll kind of talk about this later on after we go through this too.
Mm-hmm.
A lot of women they think, well, I'm not in childbearing years. I don't want any children anymore. So take my ovaries. I don't need them. And the problem with that is that your ovaries produce estrogen, right? So over time, when you're in your perimenopausal years, I mean, as you are aging, it doesn't just happen in perimenopause. As we age, estrogen decreases, your egg supply decreases, and ovulation just starts to decline until you hit menopause, and then you eventually reach ovarian failure, right? So that decrease in estrogen over time, it decreases tissue strength and elasticity. And so that happens throughout the body and the pelvic floor. And it also thins the epithelium, or the superficial layer of the vaginal canal. And so that can cause things like increased irritation and dryness, and make the tissue more fragile. And it decreases the blood flow to the area as well. So a lot of, women, again, think that they don't need estrogen once they reach a certain age. And you really do see a lot of systemic changes, not just, I can't have babies anymore. It's more of a systemic impact than just that. So we see those changes in the vagina, but we also see changes in bone health when estrogen decreases. You have more at risk for osteopenia and osteoporosis. And also heart health too, changes in cardiovascular changes over time with estrogen decline.
Yeah, absolutely. So why is the vaginal tissue so dependent on estrogen? I know the answer to this, but I think it's a good reiteration and reminder for our audience. And then we're going to talk about that magic vaginal estrogen that we can actually use.
Yes.
But what's so good about this? Why is it such really a no-brainer? It really should be prescribed to all women. And I'm hearing more and more lately. I was just listening to another show, and they were talking about, again, it's all symptom-based. Women, even in their 20s and 30s, that can benefit, again, depending on what's happening, why they need the support, but how beneficial vaginal estrogen is for that localized area.
Yeah. It's so important. I agree with you. I think that it should be something that's given to women a little bit more freely than, I mean, we've been giving men testosterone when their levels are just slightly out of whack for so many years. So why not keep women in an optimal range too, and help their tissues be healthy, right? So, when you decrease the tissue elasticity and the strength, and then also just the integrity of the tissue itself, that can make intercourse really painful, right? If you have increased irritation of those tissues, it's not going to feel great with any sort of penetration.
Sure.
And then with the decrease in strength and elasticity, if you think of a tissue, especially in the vaginal canal, we want nice, plump, moist tissue, right? That's what's supposed to be supporting the vagina and helping to keep a nice, healthy vaginal microbiome too. So once that estrogen declines, then the tissue starts to almost atrophy, right? It gets a little thinner, less elastic. It doesn't move as well. So it can cause weakness. It can cause tightness, right? In different places. And it actually has an effect on the closure of the urethra too. So, over time, women will experience possibly some leakage, issues like that. And it's because the tissue is not strong enough to assist with the closure of the urethra and help to support the urethra, right? So then we just have a little bit of leakage, and we're thinking, why? I haven't had this for so many years, and I'm strong. I work out. I do all the things. I think I have a strong pelvic floor, but it's just the integrity of the tissue that's declining over time because of the lack of estrogen. So those are the main things that come to mind and really, really assist when we have estrogen replaced into the body and into the vagina.
Right. Replace what is no longer there to its, fullest capacity. You mentioned leakage. I think this is something that we can just kind of slough off as, well, I can't do jumping jacks anymore. Or I was talking to a lady just the other day that I started to working with, and she's like, Yeah, she was running, she was starting to get back into running, and she's like, "Oh my gosh, I had to run to the restroom beforehand because I was afraid." So this is starting to become an occurrence for her. And then of
Hmm.
course we dove into the whole vaginal estrogen. Again, she didn't understand the benefits. That this could really be her kind of her secret sauce. Her
Yes,
secret lotion,
exactly.
right? So amazing how something but again, I think it's important to get this on board sooner than later,
Hmm.
just to over time protect those tissues.
Yeah, absolutely.
Another common thing that is talked about and women suffer with is bladder infections and UTIs.
Hmm.
I'm lucky, knock on wood, I've never had either. I'm not sure why, but I'm lucky I
Hmm.
never have experienced those. But tell us about that too. Another thing that doctors will kind of put in a silo, treat you with an antibiotic. And, we know what the downward, negatives about it being on antibiotics are,
Hmm.
but where this again can be mitigated.
Right. And there's a couple different things that I talk about with my patients who have recurrent UTIs. And a lot of patients just say, I have recurrent UTIs. But I always ask the
Hmm.
question, are your UTI, is the testing that your doctor is doing coming back positive, or is it not?
Mm.
That's a huge question that I ask, because if it
Okay.
actually is an infection, then sure, we may have some integrity issues, right? In the vagina and the urethra. Thinking about the estrogen receptors throughout the body, they're in the bladder, the urethra, the vagina. So think about everything I mentioned earlier, right? Declining
Hmm.
with
Hmm.
estrogen decline, the tissue elasticity and integrity. All of those changes are also happening the bladder, the urethra as well. So yes, if the tissue is actually compromised slightly and we're having more increased actual infections, then that is something that estrogen, reintroducing that can help with. And then also, if the people are actually saying, I'm actually not sure, my doctor just gives me an antibiotic, right?
Okay.
Or, yeah, it was negative, but they put me on an antibiotic as kind of like
Interesting.
a preventative, or just to try to see if it makes my symptoms better.
Hmm.
A lot of the times I see women who think like that they have a UTI, and it's actually just the tissue integrity and
Okay.
the irritation in the vagina or surrounding the urethra
Okay.
that's causing UTI like symptoms, right?
Oh,
Burning with
interesting.
urination,
Okay.
feeling like you have to urinate a lot, very frequently.
Okay.
And that can be because of irritated tissues. It can be because of tight tissues. And so I think people get into the habit of just saying, "Oh, it's a UTI. Let me just call my doctor and see if they'll prescribe me an antibiotic." But I do think it's really important to make sure, are we actually dealing with an active infection? Or are we dealing with angry pelvic floor muscles that are kind of mimicking the symptoms of a UTI?
Mm. Yeah, yeah, that's really interesting. And again, all of that is so important to understand and to be able to unpack we think we know what's going on. So
Hmm.
vaginal estrogen, which is, we'll just kind of top this off with, just kind of clear. This is something that, it does have to be prescribed right now.
Hmm.
It's not over the counter. It is in
Hmm.
Europe. It is not here. Something that again, but it's something I think if and when these symptoms are starting to go off for women, depending on her age, it's definitely something to request. I know just our providers, just our everyday medical providers, whether it's an endocrinologist with diabetes or an OBGYN or whoever you're seeing for your hormone health or
Hmm.
just your PCS, your primary care, it should be easy to request. This should be an easy prescription. I know I get my tube at the local pharmacy. It's $20 a tube, lasts 2 to 3 months.
Hmm.
Again, it's preventive. And
Yeah.
I think if that's another thing that we talked about at the top of the hour is what we want women to understand. If this is one thing they take away
Yeah.
is to advocate and understand that area of the body, understanding these symptoms, interpreting what's going on, definitely see help if that seems to be obviously, the doctor that you want to address with this and visiting a pelvic physical therapist that can really just kind of confirm it. But I think it's just another example of understanding our body and advocating and saying, this is what I know.
Yes,
This
absolutely.
is not just some wild theory or just some magic lotion that everybody's talking about, but it is proven the
Mhm.
benefits long term for all women.
Yeah,
Yeah.
yeah, absolutely. And a couple things to add to that. I know I kind of spoke on this just a little bit earlier, but if we have optimal lab ranges, right? So when your doctor draws labs for you, whether they do a hormone panel or a CBC, just a regular blood panel, there are values that are within normal range, right? And typically that's what your doctor is looking at just to make sure everything's in the green, right? Everything is in optimal range. But that optimal range, I would argue, is not always optimal, right? That is
Mm.
within normal limits, right? And where your hormones or your blood levels should be. But if you're having these symptoms still and, your estrogen comes back and it's within normal range, it's still a question to ask your doctor. You're not asking for anything systemic or oral ingestion
Mm.
of estrogen to replace, right?
Mm-hmm.
But
Right.
okay, maybe your estrogen levels are still within normal range, but you're having these symptoms in your
Mm-hmm.
pelvic floor. You should still ask your doctor if there is a way that you can replace vaginally, because the vaginal option is not systemic.
Mm-hmm.
There are very few people that have systemic symptoms from a vaginal suppository or
Yeah.
gel or lotion, anything like that.
Right.
So
Mm-hmm.
it's always something to ask, and I always advocate patients to ask about it. And that's something that a lot of women who are not in the healthcare field, they just think, what the heck's wrong with me? All my labs came back normal, right? But normal is very different than optimal, right?
There
So
you go.
yeah,
Absolutely.
if they're
Amen to
normal,
that.
great, fantastic, right? But
Yeah.
can they be better? And
Mm-hmm.
I think that's always a question that we should be asking. And kind of
Yeah.
going off of that, there are very few contraindications to the use
Right.
of
Right.
vaginal estrogen too. So like I mentioned, it's not going to be a systemic hormonal response from adding
Right.
estrogen vaginally.
Right.
Of course,
Right.
there are some relative contraindications, if we've had any sort of estrogen receptor positive breast cancer, things like that, that's something to consider. It's not a contraindication per se, but it is a relative contraindication that you need to talk about with your doctor. But,
Right.
things to discuss with your doctor further rather than just accepting that they say everything is normal. Ask the questions.
Absolutely. Absolutely.
Mhm.
Absolutely. So let's pivot and talk about diabetes. Those of us with the insulin-dependent diabetes, which is an inflammatory state. It's a chronic disease. So how does this disease that we manage, how is that affecting the pelvic floor, or does it? Is it any different for us?
Yeah, I think it is. I would argue that it is for sure. I see a lot of people with chronic illness, and the less controlled a chronic illness is, the greater risk of pelvic floor dysfunction. And especially
Yeah.
like you said, basing that off of the thought that most of these chronic illnesses come along with chronic inflammation, and chronic
Yeah.
inflammation just doesn't do anything great for the body, right? So
Mm-hmm.
the longer that diabetes is not managed or blood sugar is, dysregulated, that is going
Mm-hmm.
to cause issues in the pelvic floor. It can lead to changes in tissue integrity too. And then, like we'll
Sure.
talk about as well, in nerve changes, right? Changes
Right.
to
Right.
nerves throughout the body. So
Yes.
it can lead to changes in bladder function and decreased muscle strength and
Mm-hmm.
reduced elasticity, kind of like all of those things with decreased estrogen do. And a higher risk of UTIs with increased glucose in the urine, things like that
All
can
those
cause
things.
more bacterial
Yeah.
growth. Yeah. So
Yeah.
it definitely has a huge impact on the pelvic floor and just pelvic health in general.
Yeah, yeah. And
Mhm.
I talk about how hormone therapy it's a beautiful icing on the cake, but we still have to focus the best we can on the foundation and taking care of the terrain of the body. And, obviously blood sugar management, keeping that time in range is going to help the tissues, well, throughout the whole body, the nerves and the tissues.
Mhm.
But if and with that, I mean, you're not going to, I think, just get prescribed vaginal estrogen and, take it and think, oh, well, this is going to solve my problem. This is going to maybe I won't have the UTIs anymore. But it does still come back to really, really focusing on those everyday things that we need to do, support blood
Mhm.
sugar, lowering stress, and all the things that we can talk to. So I just wanted to reiterate that it's
Yeah.
important. As magical as vaginal estrogen is for all women, yeah, we gotta focus on the basics as well.
Exactly.
Yeah.
Yeah. Thinking
Yeah.
of vaginal estrogen as an adjunct to the rest of what you have to
Right.
make
Right.
lifestyle changes for, keeping your diet healthy as possible, right? Doing your best every day to stay active, and the chronic stress too. I mean, chronic
Right.
stress is going to correlate with chronic inflammation. So,
Yeah.
I
Yeah.
mean, I wish that there would be a magical vaginal suppository that would keep us
Right.
in
Right.
a nice neutral area with all of those things. But there is work to be done, like you mentioned, outside of the
Mm-hmm.
suppositories, for
Mm-hmm.
sure.
Mm-hmm. Okay. Now let's, this is a common question, that I get and I've asked myself. So working as a pelvic physical therapist, and you may get this when women come to see you. So what actually happens during an evaluation?
Yeah. So I love, first day I do physical therapy visits in my clinic here and then also in home. And I have found that, it depends on the person where they feel the most comfortable. But
Mm-hmm.
that's really why I give that option too, because I want you to feel as comfortable as possible with this visit, because it is, sometimes a very intimate topic to discuss with somebody, especially who you're just meeting. So when I see you for the first time, we do a lot of talking first. So we talk about your history, your medical history, pelvic floor history, what you've tried, what's not worked, what has worked. And I would say I spend most of my time talking with my patients on day
Okay.
one, because I think it's important to establish a relationship and make
Yeah.
sure that you can have them as comfortable as possible. And, you know, it doesn't do anybody any good to rush into things. So we talk a lot on day one. And
Yeah.
then for my examination, I do everything external first. So I'm looking at
Okay.
your posture from head to toe. We're looking at changes that we can even make up at the shoulders and the neck. The
Mm.
jaw has a huge connection to the pelvic floor. So I'm looking at
Interesting.
that. I'm looking at your breathing. I'm looking at your core contraction, your muscle strength in your legs, your foot posture, all of those things first before we dive into any sort of internal work. And
Okay.
of course, I try to really take an approach to where I am sensitive to anything, any sort of trauma that anyone has ever gone through, right? And so I practice trauma-informed care. And so what that means is I'm always going to give you the option of what you want to be done in a clinic or in-home session, right? Again,
Gotcha.
that goes back to the comfort, making sure that your patient and that human is just as comfortable as
Sure.
possible. So always asking, for consent, of course, that's just a given as what we should do as therapists. And I probably overdo it. And I have a lot of patients who, can I touch your shoulders? Can I touch your hips? And they're like,
Okay.
do what you got to do. It's fine. But I'm still going to ask because it's just one of those things that it could be a trigger for somebody and you have no idea.
Sure.
So
Sure.
when you get into the internal exam, it's really simple. And I always tell this to my patients. We go through on a pelvic model first. I brought my pelvic model to show you, but
I love it.
I
Love
always
it.
show them on a pelvic model first, what we're going to be doing. It's a one finger examination, gloved with sensitive lubricant. And I'm going to check out a couple different layers of your pelvic floor. So think about it kind of like each depth is almost like a knuckle, right? So layer one, layer
Okay.
two, layer three, just about, right? Everybody's a little bit different too in their anatomy. And I'm checking for how the tissues feel. I'm checking for the strength, any sort of tightness or tenderness that we feel. Are you able to coordinate that contraction with your core and with your breathing? I'm looking at all of those things and then some. And I always tell my patients this is going to take 5 to 10 minutes unless we want to spend more time, right? It's
Okay.
never a very comfortable thing for most people, especially on day
Sure.
one. So I try to make my exam as quick and efficient as possible.
Okay.
And so if we move forward with the exam, that's most likely what it's going to look like, unless we want to spend more time. If my patient's really comfortable and is like, hey, if this is a tender spot and we want to work there today, let's do some internal release. Perfect. We
Okay.
can do that. Either way, that's what day one typically will look like with an internal
Okay.
exam. Then, you get changed, get dressed, and then we talk about everything that we found, right? So from head to toe, from the start to the finish, what we found during day one, and then where we're going to go with a plan moving forward. So what we're going to do to address each of these issues, about how long I think that might take. And I always emphasize the commitment on the patient's end, right? I can do a lot in clinic and hopefully make you feel at least 10% better on day one with treatment of whatever we decide to treat on day one. But the real work comes with what you are willing to do on your own time, right? So I always emphasize that it is a shared journey, right? I'm going to do my best to make you feel better with my hands and with my knowledge, but you need to also make yourself feel better by doing what I ask of you, exercise-wise, education-wise, and really following through on that end. Otherwise, it's not going to stick and you'll be seeing you a lot longer than what you expected.
Understood. Okay. All that makes sense. So is internal work always have to be done?
No, never, never. Yeah. I have treated many women virtually too, where we have never done an internal exam. Even if I do have a virtual patient, I always go over with them if they would like to perform a self-internal exam, just so that they feel comfortable if they want to get to know their body a little bit better. I give them resources to know how to do that on their own, but I've treated many women very successfully with no internal exam at all. So if you ever do see a provider and they say, this is going to be really valuable and I think we need it, and, and it feels forced, it should never feel forced. It's always optional. And even, I have some women who come in on day one and then sessions 2 through 4, and they're not really interested in the internal exam, and they're just not really seeing a ton of results, and they think, okay, now I feel comfortable. Let's maybe go into the internal work and see if there's things that we need to work on there. And if they feel comfortable at that point, then that's perfect. But never has to be done.
Yeah, I love that. And it's just, again, bio-individual. Every woman's pelvis is different. The same, but different, right?
Yes, exactly.
Yes, yeah. So some of the treatment options, and I'm going to throw some out there, like Kegels is something that we hear a lot about. And that sounds like that might be something that we can do on our own. So you send us home with some Kegel exercise homework, I'll call it. Is that similar to what you're kind of recommending, or is that just kind of, that's a very blanket overall statement that needs to be updated?
Yeah. Yes. So I love that you brought that up, because I think that is a common theme that women believe, right? Is just Kegels are good for everybody. They're gonna help to strengthen my pelvic floor, and everybody needs that. The problem is that not everybody needs that, and until you are assessed by a pelvic floor physical therapist, I always say, don't be Kegeling your life away, right? I think it's important during an examination. I always go through a pelvic floor contraction or a Kegel with my patients and make sure that they understand how to coordinate that contraction. But oftentimes I am never prescribing Kegels in isolation. So it's not that they're bad. I will never bash a Kegel. I think it's important to understand how to contract and activate your pelvic floor. But even in the research, it does show that it is more beneficial if you are going to do a Kegel to perform that with exercise. So, sitting on the couch or sitting at a stoplight and doing 10 Kegels, it's not going to necessarily be the worst thing that you can do, but there are better alternatives. And especially, like I mentioned in the beginning, if you have not been assessed by a pelvic floor physical therapist, if you have tightness in your pelvic floor and that's the main issue, we should not be Kegeling all day. That's probably one of the worst things that you can do, because
that's
you are
the
just
opposite of what you need.
Exactly. You're activating an already overactivated muscle. So, after that first session, that's something that might be considered along with other exercises, but a Kegel in isolation, it's not functional. And I'll talk on that for just a moment. Your pelvic floor is supposed to react, right? So, when you are in the grocery store, your pelvic floor is supposed to be activated while you're walking around so that you don't lose urine, right? So if we're training our pelvic floor to contract and relax and contract and relax, that's not functional for every day, because you shouldn't have to, I'm going to stand up from this chair. Let me do a Kegel so that I don't lose urine. You shouldn't have to do that, right? That's not how your pelvic floor is naturally supposed to work. So I never use that as a tool unless I'm using it functionally with exercise.
Okay. I love this. Yes. So you get to know the woman, what she needs, and then treatment is delivered accordingly. Speaking of, so what about dry needling? This is something that I've become more aware of too. I do happen to know a lot of you physical therapists in our town here. So this is a practice that I know is getting more attention. So is this something that you've been able to help the pelvic floor or the pelvic pain with?
Yes. Yeah. Dry needling can be very, very effective. There are tons of muscles in your pelvic floor and then the surrounding structures. I use a lot of dry needling myself in the glutes and the low back, the SI joints. They
Okay.
really respond well to dry needling. There
Okay.
are other clinicians who use a lot of pelvic floor dry needling specifically.
Okay.
I don't do a ton of that, but there are muscles like your obturator internus, that's a deep hip rotator muscle that is really beneficial when needled. I see a lot of patients who have a lot of success with that. So
Okay.
I love dry needling as a treatment for most people. Of course, there are indications where you won't use dry needling, or if somebody is completely averse to needles, it's not going to work. But a lot of people have great success with it. And it's nice because my hands can do a lot. And a lot of the therapists who you know too, they're heavy manual therapists, and we love to use our hands for treatment. And that's
Yeah.
how we all learned to be physical therapists, at least this group that are in our area here. And so we love using our hands, and we can help a lot with our hands. But the dry needling is just a great, effective tool that can get deeper and really internally mobilize that muscle or tissue at a deeper level than what we're able to do with our hands.
Okay. Awesome. Yeah.
Yeah.
I love this. Yeah. And, you know, we're here today just throwing some really good theories and some treatment options for people to look into. So I love
Yes.
that. So again, it's kind of equipping us for, you know, whatever that road ahead to healing is going to be.
Right.
So I want to do something a little fun. These are rapid fire questions and basically true or false. And if you want to expand on the answers, feel free. So I'm going to toss a few questions at you that I think the audience can relate to. So number one, leaking after having babies is normal.
It is not normal, but it is common. So that is a myth. And a lot of women are told that, right? Their mom has been leaking for years, so she says, it's just normal, you've had a baby. It's not normal, but it's common, and we can help that with physical therapy.
I love it.
Okay.
Next one, pain during sex is something women just have to live with.
No, my gosh, no. That should be something enjoyable, right?
Right.
So if you're having any sort of pain with intercourse, that's first something, I mean, we can help with physical therapy, whether that's pain with insertion or deep penetration. But then that also starts to, you want to ask more questions like, with the deep penetration, are we dealing with things like endometriosis, right? Or pelvic congestion syndrome, where, that deeper penetration can actually be caused by the endometriosis lesions and, them causing more discomfort. So there are things that we can do as physiotherapists, and then there are also things that we need to refer out to if we're suspecting things like endometriosis. But no, painful sex is not normal.
No, absolutely not. Again, it's really understanding that. It's so important. And again, these are symptoms that we need, the flag needs to go up and say, whoa, this wasn't happening before, even though I just had a baby, or maybe I'm getting older, or whatever.
Yes.
Those indicators might be, it's still not normal. Yeah.
Right.
Okay. Next questions. And I think you've already answered this, but I'm going to throw it out there anyway. Kegels fix everything.
No. I wish there was a quick fix, like a Kegel to fix everything, right? But no, unfortunately they don't. And again, I'll emphasize, I'm never going to shy away from a Kegel. I think that there is enough research to support that they are beneficial. But in isolation, not so much. We could be doing so much more for the pelvic floor.
It's more to it for sure.
More to it, yes.
Next question. Pelvic floor therapy is only for women after childbirth.
No, I do see a lot of women after childbirth, and that's when a lot of the, issues start to arise. However, I do see a lot of women who have pelvic pain, like I've mentioned, right? People with endometriosis, which I cannot actually treat the endometriosis. The gold standard for that is expert excision surgery. But there are symptoms that go along with that, like pelvic pain, bloating, pain with urination, bladder pain, constipation, things like that I can treat with physical therapy. I see women at all phases of life,
all ages,
all ages. So, and that's something I always emphasize is, I've seen people in their teens. I've treated women all the way up to 90 years old. So there's no age that is appropriate for pelvic floor therapy alone. There are many ages.
All ages and stages. Yeah,
All
yeah.
ages and
And
stages,
we
yes.
talked about post childbirth. I know I'm going to go off my rapid fire here, but I wanted to just kind of add to this. I think it's really important that that the listeners here are aware of the gift of pelvic floor physical therapy,
Yeah.
and to address this and to really love on that area of our body sooner than later.
Yes.
Because I'm in that age group, late 50s, where I'm hearing more and more of these symptoms coming up. I think UTIs, pelvic pain, pain during sex are the common things that women my age are experiencing, accepting. And and again, we can't turn back time. We can't say, well, maybe after childbirth and those postpartum years, if I had had that area of my body assessed and treated and nourished, maybe, now that we're in our 50s and 60s, these issues probably wouldn't be happening, or at least we'd be
Hmm.
more in tune with that area of our body and more educated and not accepting the symptoms and the pain. And this is what's going to kind of take place for for the rest of our time here, right?
Yeah, exactly.
Yeah.
Yeah,
Yeah.
I always encourage women to seek help before there's a real issue. I
Yeah.
do see a lot of women who are looking for preventative care, and I love it that that is becoming a trend, that people are reaching out to me before there's a real issue. And I think
Hmm.
that's a big thing to emphasize, especially with someone like me who provides cash pay services. You don't have to have something specifically going on. You could just want to learn more about your body. And
Hmm.
for me, I'm not going to say, hey, you want to learn more about your body? You have to come back to see me 2 times a week for 8 weeks. You can
Right.
come in for an evaluation, learn more about your
Hmm.
body, and then see
Yeah.
if we need to work more, if we need to just do
Yeah.
one session and you get a lot out of that. Perfect.
Yeah.
I want
Yeah.
you to feel good without me in the future, right? But I always encourage people to do the preventative care, right?
Yeah.
At a young age, at, whatever age, it doesn't matter. But even if you're starting now and you're 60, who cares? At least you're starting now. And
Yeah.
then we can prevent any further issues from happening because you have
Yeah.
a great education and foundation behind you.
Absolutely, absolutely. And that was going to be my next question. If you aren't having symptoms, you don't need to think about pelvic health. So,
Yeah.
needless to say, absolutely not.
Right, correct.
Right.
Yeah.
Yeah.
Yeah. I have a lot of women too, especially who are, getting into either they are pregnant or trying to conceive, and they don't necessarily have issues, but they want to learn more about their bodies and be in touch with their bodies so that if they start to feel symptoms of some sort of dysfunction, they know
Yeah.
either to come see me or they have the tools themselves to try to fix it on their own. And
Mm,
that's really the thing, if you have the tools, then that's what you need to succeed. All right. And if it's
yeah.
not working with the tools that I gave you on day one, then you have a good resource to come back to. And it's easy to, come in and see me, and I'm not gonna ever force you into something you don't want to do. Let's give
Right.
you more tools to put in the toolbox, right?
There you go. I love that.
Yeah.
I love that. Well, this has been very valuable. I've learned quite a bit, and things that if they're not front and center, and then maybe it's not something that we're experiencing, it's important to understand and to be reminded that this is a very important area. So if someone has been silently struggling, so maybe there's listeners today as we close out this conversation with you, Casey, I really appreciate
Yes.
your time. What would you say to encourage her if it kind of raised her eyebrows on some of the things that we described, some of the symptoms you mentioned, and the options and the treatment options. What would you say to encourage her?
I would say, to choose you, right? And in short, to choose you, right? And to choose a provider who you feel really comfortable with.
Hmm.
For me, I like to offer my patients a free consultation for 30 minutes where we can get on a video call and meet each other. And I think that goes a really long way because, you see somebody online or you text with them. It's okay, but you're not really learning what that person is all about and how they're going to support you. And I really feel like I want the women who I work with and the men who I work with to feel like I am on their team. And
Mm,
I want you to feel empowered to find a provider who feels like they are on your team and they want the best for you and that they're going to be available to help you when you need it. So, I would just say book the discovery call, right? Book
yeah.
the discovery call with the provider who you're looking for and see if they are going to be the one who is going to be on your team